Hi, in the lesson today we're going to talk about movement. It's important as OT practitioners that you understand about planes of movement, range of motion, and what movement is normal that takes place in the body. First of all, in your book, they talk about dividing the body into different planes. One of the planes is the frontal plane. The frontal plane would be as if I took some piece of board and went right down the center of my body so that the front half was divided from the back half. In that plane, we move in abduction and adduction. So if there was this board through me and I was to move my arms along the board, this would be abduction, abduction, and coming back down would be adduction, adduction. The same movement takes place at my legs. If I move along the board and move my leg out, it's abduction, in is adduction. Out, in, abduction, adduction. Another way we divide the body is through a vertical plane, and that would be a plane that would come right down the center and divide me in half right to left. If I move along that plane, it's flexion and extension. Again, I can do this at my shoulders, where I flex up, extend down, and I can do it at my hips, where I would flex up and extend down. The third plane we have is called horizontal plane, and that would divide me in half, top to bottom. So now I would have this board just coming right through here, and the movement that takes place there is rotation. So I can rotate this way, and I can rotate that way. I can also rotate my shoulders and my hips. So if my shoulder is here and I rotate this way, I'm internally rotating, and if I rotate this way, I'm externally rotating. Same with my hip. I can internally rotate or I can externally rotate. The next thing I want to talk about is range of motion. One of the things we'll need to know is what to call the movements that our joints do. All of our joints move, and they move through an available range, and that's what we would call normal range of motion. We're going to learn about flexion, extension, rotation, both internal and external, elevation, depression, all different kinds of range of motion. The first thing we need to understand is, where do we start in a neutral position? If I stand like this, I am anatomically in a neutral position. We think of flexion as curling up. So if I were to curl my arms up and curl my legs up and get into sort of a fetal ball, I would be flexed. When I move out, I'm extended. So that's one way to think about flexion and extension. We're also going to need to think about what is a normal range. So this is the range of motion of my shoulder and flexion. It's about 180 degrees. In this class, we're just going to learn about what normal range is and how to move people. In the 103L class, we'll learn how to measure range. But one thing I want you to get is how you can look at somebody's movement and get a basic idea about their range. And to do that, you need to think of a 90-degree angle. And a 90-degree angle is like an L. So if I say this is shoulder flexion, and I move my arm this far, you can see the 90-degree angle. I'm going to have someone else come in so we can look at this. So I'll have Linda come in. If Linda's here and she moves her shoulder out this far, here's the L. That's a 90 degrees of shoulder flexion. If I have her arm down and I move her elbow like this, there's the L. And that's 90 degrees of movement. If she sits, she has an L right here along her hip. She's in 90 degrees of hip flexion. So if you think of 90 degrees, you can kind of guesstimate where somebody's range is, so that if I was to look at her elbow like this, I know she's in more than 90 degrees. And if I was to look at her elbow like this, I know she's in less than 90 degrees. The other thing we need to know about range of motion is that there's both active and passive range of motion. When we see a patient and they have paralysis, they may not be able to move at all actively. So we may need to move their joint for them. If Linda's sitting here and not moving and I move her arm up, That's passive range of motion. If I ask her, Linda, will you move your arm up like this? And she does, then that's active range of motion. Okay, the next thing I want to do with range of motion is just show you what the different range of motions are and what we call them. So I'm going to start with my neck. I can flex my head forward, and I can extend it back. I can laterally flex my head to either side, and I can rotate my head. Next, I want to look at the scapula. The scapula is your bone that you might have called your wing bone. It's this bone right here on your back. It's a very important structure when we talk about shoulder movement. What the scapula does is it elevates, like shrugging your shoulders up, and it depresses. And it's hard to see the depression, but I can actively push my scapula down. The other thing it does is to protract and retract. Retraction is like squeezing your shoulder blades back, and protraction is like leaning them forward. So my arm is like this, and without moving my glenohumeral joint, I can take my scapula and reach forward, and that's protraction, and the movement's taking place at my scapula. It's really important to understand the scapula when we talk about glenohumeral flexion, because there is a ratio of 3:1, so that when I move my arm up into flexion, I'm moving it 180 degrees. 2/3 of that, or 120 degrees, comes from movement at my glenohumeral joint, and 1/3 of it, or 60 degrees, comes from movement at my scapula. Whenever we move somebody's shoulder passively, we want to make sure that there's scapular movement, or else we could hurt them. Okay, now I'm going to go through the range of motion of the shoulder joint. The glenohumeral joint is one of the most mobile joints that we have. We can, and it is a ball and socket joint, which is the same as our hip, and the movements are the same, but in the hip we have more stability because we need to weight bear on it and stand on it, and the shoulder joint, we have more mobility. So this is the movement. I have flexion and extension and hyperextension. I have abduction and adduction. I have horizontal abduction and horizontal adduction. And I have shoulder external rotation and shoulder internal rotation. When my arm is down by my side, fully adducted, I can do external and internal rotation this way. So this is external, this is internal. When I have my shoulder up at 90 degrees, external, internal. My elbow is a hinge joint, and it just does flexion and extension. So this would be flexion, and this would be extension. My forearm does supination and pronation. Those are the two movements it does. When I was in school and I learned this, one way they taught me to remember it was to say that when you supinate, you're in position to eat soup. So maybe that'll help you. My wrist moves in different planes. This would be a neutral wrist. If I move my wrist up like this, it's extended. If I move my wrist down this way, it's flexed. If I move my wrist towards my little finger side, it's called ulnar deviation. And if I move it towards my thumb side, it's called radial deviation. And if I move it around in a circle, it's called circumduction. Okay, my fingers also have range of motion. These are the MCP joints. These joints can flex, and they can extend, and they can also abduct and adduct. My thumb is a very useful part of my hand. Our thumb gives us opposition. With my thumb, I can extend, I can abduct, and hopefully you can see the difference. Extension is like what I would do if I was hitchhiking, and abduction would be away from my palm. I can also flex my thumb and extend it, and I can do opposition with my thumb. So that's what gives me my ability to pinch and to have a power grasp. Okay, Now we're going to move down to the hips. Like I said, the hip joint is like the shoulder joint. I can flex it. I can bring it back down or extension. I can hyperextend it. I can abduct it, abduct. I can adduct it, adduct, bring it back. I can internally rotate it, and I can externally rotate it. Okay, my knee, more like the elbow, just does flexion and extension. So this would be knee flexion, and when it's in fully extended, when it's in this neutral position. My ankle, with the ankle, we don't call anything extension. We would call it, when we move it up this way, it's dorsiflexion. When we point it down, it's plantar flexion. And we can also invert and evert our ankle. It's very important that we can invert and evert, because if we're walking on cobblestones or a sandy beach and there's uneven surfaces, our feet move around so that we can keep our balance and have range of motion. One more thing that's important to understand is movement against gravity. We've talked a lot about the role of gravity, and we take moving against gravity for granted because this is how we've moved all our lives. But when someone has a lot of muscular weakness and they're just recovering from some paralysis, gravity plays an important role. When we look at muscle grades, we talked about full movement against gravity or with gravity eliminated, and I just want to make sure that everybody understands what that looks like. If I take my elbow and I move like this, I'm moving against gravity. If I'm bringing it back down, I can just let it drop and gravity will pull it down. So against gravity, elbow flexion. If I were to put my hand on a tabletop or put it in this plane, now when I move my elbow into elbow flexion and extension, gravity is eliminated. I'm not moving against gravity when I flex, and I'm not having gravity assist when I bring my arm into extension. Sometimes when we do aerobics classes, if the teacher wants us to work on elbow extension, they'll have us move our arms like this and then move our elbows back. And the reason for that is in this position, I'm extending my elbow against gravity. This is the same thing with shoulder, external rotation against gravity. But if I bring it this way and externally rotate, I'm eliminating gravity. So one of the things we need to understand is how we eliminate gravity when we ask people to move actively.